transportation hub, and I think all of us here today are really interested in that kind of concept. And I know that the executive leadership team is also interested in that. So moving forward, I just want to say as we start off, we're going to be kicked off here today with a great visionary in heart failure. And really, heart failure was the concept that we wanted to use for this particular forum. And to have Bill Abraham from the Ohio State University come and speak to us today is really a great honor and a privilege. And so I'd like to ask the division chief of the cardiology section at the Ohio State University, Bill Abraham, to please come up and speak. Thank you.
Well, thank you very much. It really is my honor to join you today for this very unique program and Innovation Summit. I was asked to speak briefly on why heart failure now. So I'm going to take you through a few statistics about heart failure, which I suspect are well known to many of you in the audience. But I'd first like to describe the magnitude of the problem, and then we'll talk a little bit about innovations in heart failure therapy, focusing on some recent developments and a new FDA-approved device, as well as many other innovative technologies which are under investigation for heart failure. So why heart failure now? Well, despite currently available drug and device therapies for heart failure remains a major and growing public health concern. There are at least 5, maybe closer to 6 million Americans who suffer from symptomatic heart failure. About 650,000 new cases of heart failure are diagnosed each year in the United States. The lifetime risk of developing heart failure is 20% for Americans over the age of 40 years. Now think about that, because at least a few of us in this audience are age greater than 40 years. 20% lifetime risk for the development of heart failure. Approximately 50% of heart failure patients die within 5 years of diagnosis. Heart failure is the primary diagnosis in more than 1 million hospitalizations annually, and the outcomes from those hospitalizations are quite poor. I'll highlight that on the next slide. And in 2010, there were 1.8 million physician office visits, nearly 700,000 emergency department visits, and 236,000 unscheduled outpatient department visits with a primary diagnosis of heart failure. So as I mentioned, heart failure accounts for more than 1 million hospitalizations annually. That's where heart failure is the primary cause of hospitalization. There are another 2 or 2.5 million hospitalizations annually where heart failure is listed as a secondary diagnosis. But if we focus just on those 1 million primary heart failure hospitalizations, it's fair to conclude that one of the worst things that can happen in the lifetime of a heart failure patient is for them to be hospitalized. Because once hospitalized, here's what their outcome looks like. They are at high risk for mortality, about a 4% chance of dying while in the hospital, and a 10% chance of dying within the 30 days post-discharge. At 1 year, the mortality rate is more than 20%, and at 5 years, it approaches 50%. In addition, readmission rates are also unacceptably high. The 30-day readmission rate for heart failure is about 27%. Heart failure is associated with the highest 30-day readmission rate when compared to all other causes, both medical and surgical causes of hospitalization. And at a year, the rehospitalization rate for heart failure approaches 70%. Heart failure is also associated with a significant financial cost or burden. It's estimated by the American Heart Association that the indirect and direct costs of heart failure are about $31 billion. The direct costs about $21 billion, and about 80% of the direct costs are attributable to managing episodes of heart failure decompensation, primarily hospitalization for worsening heart failure. So of course, one of our primary clinical as well as economic goals in the management of heart failure is to keep patients well and keep them out of the hospital. You'll see that the American Heart Association predicts that the costs for heart failure will rise to about $70 billion by 2030. Now, I don't want to focus simply on acute decompensated heart failure or hospitalization for heart failure. I also want to emphasize the fact that even patients who have chronic stable heart failure, our outpatient population, are also still at substantial risk for morbidity and mortality. And again, this is despite ACE inhibitors and ARBs, aldosterone antagonists and beta blockers, ICDs, and cardiac resynchronization therapy, our current guideline-directed medical therapies. You can see that even in class 2 heart failure patients, those who we would judge to be doing pretty well, they're subject to about a 6% annual risk of mortality. And as one moves into class 3 and class 4 heart failure, that annual mortality risk rises to about 10 to 20%. Now, these statistics have not been lost on scientists and on industry. So there is a lot of new drug and device development ongoing for heart failure. And in fact, if one looks or queries clinicaltrialsgov, which I did a couple of days ago to look at ongoing or current cardiovascular clinical trials, you'll see where science and where industry is focused. They're focused on heart failure at the top of the list. So the total column looks at all trials under each category listed currently at clinicaltrials.gov, and then the far right column are those actively recruiting trials. So middle column, ongoing studies, some of them have completed recruitment. The right-hand column, those which are still actively recruiting. And you'll see if one queries heart failure, heart attack, or myocardial infarction, atrial fibrillation, or sudden cardiac death, the focus today is on heart failure. So this is why heart failure now. It's a major public health problem, and we're focusing an awful lot of energy, attention on our science and our industry in developing new solutions for heart failure. So because my time is very short, let me just go through a brief a brief and not comprehensive list of some of the new technologies that are being developed to address this problem, and then I'm just going to focus at the end on two, one recently FDA approved device and another technology that is under investigation as examples of innovations which are bringing value to the treatment of heart failure. So there are a number of newer electrical therapies under investigation for the treatment of heart failure, including cardiac contractility modulation and a variety of approaches to neuromodulation or neurostimulation, including baroreceptor activation therapy, vagal nerve stimulation, spinal cord stimulation, renal denervation, and transvenous phrenic nerve stimulation. Now, we also have something for the interventionalists. There is a growing list of interventional approaches to treating heart failure, including percutaneous ventricular partitioning devices, interatrial, it's a typo, interatrial shunt devices, percutaneous valve repair or replacement, such as TAVR or the MitraClip, and percutaneous approaches to providing ventricular assistance. The surgeons have to get in on it as well, so there are a variety of emerging surgical approaches, including ambulatory counterpulsation technologies, ventricular support and reshaping devices and surgeries, and second and third generation left ventricular assist devices. And finally, and what I'll focus on with the remainder of my time, are newer congestion monitors for the treatment or monitoring and management of heart failure, including wearable fluid monitors and implantable hemodynamic monitors. And so I want to focus on the latter for a moment to show you some of our successes and some of our ongoing attempts to improve outcomes in heart failure patients. And they're really predicated on the observation that the primary target in heart failure and the proximate cause for heart failure hospitalization is congestion, hemodynamic congestion, which precedes clinical congestion that ultimately results in worsening shortness of breath and the need for hospitalization. And here are data from Lynn Stevenson and colleagues from an old study of a right ventricular implantable hemodynamic monitor called the Chronicle device, which demonstrate the relationship between pressure here pulmonary artery diastolic pressure, and the risk for worsening heart failure events, heart failure hospitalization, heart failure emergency, department visits, and unscheduled heart failure clinic visits. And what you see along the horizontal or x-axis on this slide is increasing pulmonary artery diastolic pressure. On the y or vertical axis is the risk for heart failure events. And what you'll note here is that starting at a pressure of around 22 to 25, there is a near linear increase in the risk of having a heart failure event from a pressure in the mid-20s down to perhaps the mid or low teens. There is a linear reduction in risk, and then there's a plateau, perhaps a little bit of a hint of a J-shaped curve here. So one can hypothesize from this information that these patients are too wet and at high risk for heart failure hospitalization. These patients perhaps are a little bit too dry and at risk for hypovolemic dehydration events such as hypotension or syncope, and that these patients are just right, patients who have pulmonary artery diastolic pressures between about 10 and 20 or so, and these patients perhaps present the lowest risk for heart failure rehospitalization. Well, that's a testable hypothesis, and it was tested in a trial that I'll review with you in a moment called the CHAMPION trial using this device. But I want to use this device as an example of how academia and industry can combine to create new innovative approaches for heart failure therapy. So this device was developed by an interventional cardiologist at the Cleveland Clinic, who then worked in concert with other scientists around the country, most notably at the Georgia Institute of Technology, to develop an innovative pressure sensor. It's shown here on the upper right-hand corner of this slide. This is a wireless, batteryless pressure sensor about the size of a small paper clip that can be deployed, implanted in a branch of a pulmonary artery using simple right heart catheterization techniques and a right heart catheter-based delivery system. Now, the elegance of this system is that it has no battery, so there's nothing to run out or to be replaced. And it has no moving parts. There's really nothing to wear out or to break. And in more than 600 implants done in the US beginning about 8 years ago, there have been no pressure sensor failures. The sensor is implanted into a branch of a pulmonary artery. The way that it works then is that the patient has a home electronic system. There is a pillow which puts the patient into a semi-recumbent position, and embedded in the pillow is an antenna. The patient simply pushes one button, and via the home electronics, the antenna embedded in the pillow, radio frequency is used to simultaneously power the sensor and extract the pressure data, and to send that pressure data to a secure HIPAA-compliant website for clinician inspection. Now let me blow this up a little bit and show you what that information looks like. One can get discrete pressure data at any time point. You can look at the pulmonary artery pressure waveforms, and then you get the trended data shown in red, pulmonary artery systolic pressure, blue, pulmonary artery mean pressure, green, pulmonary artery diastolic pressure. And I'm going to share with you briefly the results of the CHAMPION trial, which tested this device. But I want to mention that this patient example, which I've shown here, is exemplary of the approach used in the CHAMPION trial, which was if the pressures were elevated at the time of implantation of the sensor, even if the patient was not symptomatic, even if the patient looked good, the investigator was instructed to make medication changes in order to lower the pressure and then keep the pressures low throughout the period of study follow-up. So the idea here was to lower the pressures into a normal range, which we thought would be associated with a lower risk of heart failure hospitalization, and to maintain it there. This is stability management rather than crisis management of heart failure. So this was tested in a 550-patient randomized controlled trial called the CHAMPION trial. Patients were randomized, all patients received the device, and patients were randomized to a treatment arm in which the physician had access to the pressure sensor data. or to a control arm in which that access was prohibited or blocked. They were followed for 6 months for a primary endpoint of heart failure hospitalizations, but all patients were maintained in their randomized single-blind study assignment until the last patient reached 6 months of follow-up, allowing an assessment of long-term efficacy as well. So the hypothesis which was tested was as follows. In addition to basing treatment on signs and symptoms, medication should be adjusted based on pulmonary artery pressures unless contraindicated by the clinical status of the patient, and that should result in a reduction in heart failure hospitalizations. I can't show you all the data from the CHAMPION trial. We just don't have enough time, but I'll summarize it with a single slide which looks at both the primary endpoint as well as the extended follow-up data, demonstrating a significant 28% reduction in heart failure hospitalizations at 6 months, and a reduction of 37% over the full duration of randomized follow-up, which averaged about 17 and a half months. This device, as I mentioned, was approved by the FDA on May 28th of this year. We did the first commercial implant at The Ohio State University on June 9th, and this is now undergoing a commercial launch in the US, and we're accumulating more and more implants nationally, which will ultimately be included in a very large post-approval study or registry. Now I'm going to conclude with one last technology. This is an investigational technology. This is not yet FDA approved, but again, it shows you how interesting technologies can be adapted to medicine, perhaps to improve patient outcomes in heart failure. So this is a radar-based, wearable, non-invasive radar-based technology for the assessment of lung water. It essentially takes technology that was developed by the military. This is a technology that allows the military to see through walls. This was developed in Israel. It's used to see terrorists on the other side of a wall. It's also been used in locating earthquake victims in rubble, and it has now been adapted into a wearable technology that can provide an absolute measure of lung water. So this might be an alternative to an implantable hemodynamic monitor if the whole story works out here. So this system uses radar in order to isolate an area of interest, here lung tissue, and unlike impedance-based technologies which provide a relative measure of lung water, you can get an absolute measure of lung water. And if you're really interested in this technology and how it works, you can go to this paper published in the journal Congestive Heart Failure, where the technology is described and all of the preclinical and first-in-man data are presented. But let me just show you one example, and this is my last slide, of how this technology performs. We're getting ready to launch in the first quarter of next year a large randomized controlled trial in the US of this system to try to prove its efficacy in patients immediately following discharge from an ADHF hospitalization. So here are 2 patient examples from an observational study using this radar-based technology. The clinicians were blinded to the data, so this looks at the natural history of one patient who was treated in the hospital. You'll see when they were admitted, their lung was comprised of nearly 55% water, fluid, increased blood volume and fluid. They were adequately diuresed during the hospital, and then over the subsequent 3 weeks, you can see that their lung water stayed within a normal range. We now know this for the first time ever. The normal lung is comprised of about 20 to 35% fluid, and this patient was not rehospitalized. Here's what happens to a patient that gets rehospitalized. They're diuresed during the hospital, they're discharged, and this particular patient almost immediately begins to retain fluid again, and the lungs become wetter again, and the patient was rehospitalized. So the hypothesis that we'll test in this new randomized controlled trial to start early next year will be that by looking at these patterns of changes and intervening and maintaining lung water in the normal range, we can reduce the risk of hospitalization following an acute decompensated heart failure admission. Well, that's just a little bit of a sampling of what's going on in innovations in heart failure. In summary, heart failure represents a major and growing public health concern. and a substantial clinical and economic opportunity for new drug and device development. Thank you for your attention.